Everyone. First of all, I would like to thank Microlabs, Trustwell Hospital, Dr. Deepak Haldipur and Dr. Vishwas for this opportunity to conduct this panel discussion on evaluation and management of post-stroke dysphagia. I am Dr. Sanjay Subaya from Bangalore. We have a very high-level panelists in the alphabetical order: Dr. Farah Naz, Dr. Manju Isaac, Dr. Nilanjan Baumik, Dr. Rashmi Nair, and Dr. Shama Kaule. I think if the panelists would like to say hello, you can just tell to our viewers.
Hi.
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 Yeah.
Let's
So
hope this turns out to be a fruitful discussion.
Sure. We'll do it. And yesterday we have had a very wonderful discussion. So it's nice that today we are starting with dysphagia. Before we start the panel, I'll give a brief introduction. I'll make the background for dysphagia. The European Society for Swallowing Disorders has defined dysphagia as dysfunction of one or more parts of the swallowing from mouth to lower sphincter. And broadly, dysphagia can affect neurological patients or head and neck cancer patients in adults. Neurogenic, earlier, swallowing was considered to be a brainstem act, but now there's increasing proof that it is cerebral cortex also plays a major role, and sensory feedback is also a major role in swallowing. So in neurogenic dysphagia, basically, there is a reference from the neurologist, basically for us to let them know if we can feed the patient or not feed the patient. See, our role in diagnosis in neurological disorders is very limited. So basically, why they refer to us is to advise them if the patient can be fed or no. So broadly, as ENT surgeons, we are concerned in the pharyngeal stage of swallowing, which lasts only for 1 second, where the pharynx gets converted from respiratory to digestive and back to respiratory. If there is any problem in this, it can lead to catastrophic damages or dysphagia. Stroke is relatively, unfortunately, it is getting common. And also, unfortunately, in acute stroke, 50 to 80% of oropharyngeal dysphagia is seen. Fortunately, 75% of dysphagia resolves within 15 days. Unfortunately, 25% of them still have dysphagia. So stroke is broadly supratentorial and brainstem. Supratentorial is commonest. Cognitive functions can be affected. Dysphagia chances are little less. Whereas brainstem, fortunately, is rarer, but dysphagia chances are quite higher. Cognitive functions are intact. So broadly, in dysphagia, you could have safety issues or efficacy issues. Safety is when the bolus enters the airway. Efficacy is when the bolus remains in the pharynx. Now, with this background, I'd like to involve the panelists, and I would like to know from them what are the protocols they follow in their hospitals, at what stage they come into the picture as a dysphagia practitioners, and who are, if they have a teamwork, who are the other members of the team. Please, we can start in the same alphabetical order. Dr. Farah, Dr. Manju, please, one by one, you all can tell.
So usually stroke patients are a referral base for us. So the neurologist admits these patients and takes care of the acute stage of stroke and stabilizes the patient. Once the patient is out of danger, according to them, and the patient has been stabilized with no active bleed or cognitively the patient is a little better, that's when we get a reference for assessing the swallow. However, the initial assessment or swallowing screening, what we call it, is done by the ICU team itself at our center. Usually trained nurses and the intensivists give the first swallow screening there. And once they feel that the swallow screening is a fail, that's when we come into the picture and a referral is given to the voice and swallowing clinic at our place. So that's the protocol that we follow.
Very nice. Dr. Manju and rest later
Yeah.
on, Bhomik and Rashmi and Yash.
Same for me also. Like nowadays, there is an awareness in the center where I work among the neurologists that they send for consultation for dysphagia as well as for decannulation protocol, both. And for dysphagia, like once patient gets stabilized, I get a call, and I'll be the first person to go and see the patient. And sometimes our SLP fellows also accompany us. And by the time we see the patient is on an alternative method of feeding, or they will hold the oral feed till they get our opinion,
Very
like
good.
by an instrumental evaluation. So the wait for us. So because of that, I think the patient with the aspiration pneumonia, that number has come down. Like
Yeah. Very nice.
nowadays.
Very nice. Dr. Nilanjan, yeah.
In our center, well, the protocol is more or less the same. The only thing out here is I prefer to do the swallowing screens also myself most of the times. Visit the ICU or the bedside of the patient and see as to whether the patient is in a position to undergo further instrumental evaluation or not. So that is something that I prefer to do most of the times, even if the ICU team has done it once.
So what is the screening you follow, Dr. Nilanjan?
So by screening, I usually do something called a water swallow test, wherein first of all, the patient's history and the patient's evaluation, of course, the sort of stroke that the patient has suffered, the patient's MRI, which regions are affected, and then of course the patient's voice, cough quality, and everything, and finally do something called a water swallow test and see whether the patient's laryngeal elevation, the patient's swallow initiation, whether the patient is able to, patient coughs after a sip of water, whether the cough is immediate or delayed. So all of this is something that I do when I visit the patient bedside. It is after that that I actually decide whether the patient is to be posted for an instrumental evaluation or, for the time being, the patient is still not fit for an instrumental evaluation.
Okay. Dr. Rashmi and Dr. Shama, you all can answer.
Actually, in our center, one of the hospitals, we have an aspiration prevention team there. So what they do is initially itself, if the GCS score is less, we follow a certain protocol for it. And if the patient is a high risk one, then we'll go for a evaluation by the swallow therapist. If the GCS is less and the patient is alert and conscious, we go for an E10 scoring system. Screening assessment is done. And if it is more than 3, then speech pathologist will be evaluating, and then only we come into picture.
So from what I understood, the severity of stroke determines whether the patient undergoes dysphagia screening also, or all patients undergo screening.
Not all patients, but all patients will be given an aspiration prevention protocol, which is common to all, depending on the high risk patients, especially in the ICU.
Okay, Dr. Shama, yeah.
So for us, if there is a dysphagia, it is first screened at the ICU level, or we have a stroke unit, so it is screened. And then if required, if they feel that there is a patient is unsafe for swallowing, then the reference is given, wherein me along with my swallowing therapist will go and see the patient and decide, first do a bedside swallowing screening, look at the cognitive level of the patient. If the cognition is not proper, then we straight away tell them to put the patient on a rise tube or alternative methods of feeding. And then if required, if the patient is cooperative, we see whether he is, in spite of cognitively being good, if he's cooperative or not cooperative. If the patient is cooperative, then we go ahead with a bedside swallowing assessment. After the bedside swallowing assessment, if we feel that he needs an instrumental evaluation, then we decide which instrumental evaluation. Generally, it is FEES as the first choice of instrumental
Okay,
evaluation.
we'll
That
come to
yeah.
that later. Now we'll just think. So anyway, so I think all of us are unanimous that all stroke patients need some amount of screening or at least scoring, and to find out at-risk patient who needs a thing. I just made a brief write-up. I mean, a small points. What is a safe swallow on the bedside? So basically, patient is mentally alert. He follows. There's not much voice change, cough. He's able to handle his secretions. And on examination, when you swallow, you can see laryngeal innovation. Would anyone would like to modify or add anything? This is just a bedside for a person to just know if it's a safe or thing. If no one has anything, I'll go to the next slide. So anyway, this is the screening test, which we have already discussed about, that water swallow test. You can ask Dr. Farah what water swallow protocol you follow, or you do anything else for testing. Is it the same thing?
So, I really like the Yale Swallow protocol, sir,
Okay.
because it's
Would you
just not
mention that?
the.
Because I haven't written here. Yeah.
So, Yale Swallow is a very nice screening protocol that I like our people to follow. First is we check the mental status of the patient. Two, it goes ahead with the oromotor examination. And third, they go for the water swallow test or the challenge. Now, ideally, they start off with single sips of water to check around 1 ml as to how the patient is identifying and able to swallow with the cognition. And then they go with increasing the amount of water that they take to 5 ml and then sips up to 20 ml, which would be an adequate challenge for the patient. So, this is what is the water swallow test that we follow.
And you use a pulse oxygen, I mean, oximeter thing, or you look for clinical drooling, cough, and change in voice?
So, though pulse oxy helps us a lot, like it is said, when you're actively doing the water swallow test, and if there is a fall in saturation by 5 or immediately, over a period of 10 minutes to 2, but the sensitivity of this is quite low. I think when we are examining the patient, and if there is gurgling, there is cough, the patient is choking, that gives us a good idea that
Yeah, so
the
coughing,
patient is.
drooling, and voice change are important clinically. So you give importance to clinical rather than oxygen saturation.
Right.
Yeah. Would anyone differ from that?
No, wouldn't differ, sir. But then there's something that I would like to add.
Please.
There's some evidence that while we are all doing, even I have not started it, but while we are all doing water swallow tests as a screening protocol, probably doing multi-consistency tests have better outcomes and you get a better understanding of the both swallowing safety and efficacy.
Yeah, that is that hugging.
So that
So there is some evidence to that effect.
Yeah.
So that is just something I wanted to address.
Yeah. I think
So
Prema
even
wants to-
yeah, the Toronto bedside swallowing test also suggests that you should give different consistencies.
Yeah.
And that has shown a good screening as a screening protocol as compared to what Yale or any other
Correct.
screening test.
So the background of using multi-consistency was because in water swallow, you can make out it's safe or unsafe. So if it's unsafe, then you keep the patient nil orally and then ask for instrumental evaluation. In many hospitals, they don't have access to instrumental evaluation daily. It might take 2-3 days. So if you do a multi-consistency screening, at least you will know what consistency patient can have safely. So that was the advantage, which started from hugging, which is in the outskirts of Vienna, and from there it's so anyway, it's nice that all of us have agreed that there should be some form of screening. There is in fact strong evidence, and all patients who fail screening test should be taken up for instrumental evaluation. And I feel without screening, the patient should not be started orally. There are some other predictors of dysphagia. I think we have already discussed that. So, Nilanjan, would you like to a little bit elaborate? So then afterwards we do the screening, and then we decide the patient, we take them up for this
Fees evaluation.
endoscopic instrumental evaluation. And I like how Dr. Shama said, as ENT surgeons, the commonest would be flexible endoscopic evaluation of swallowing. So, Nilanjan, would you like to elaborate on this?
So a FEES is basically done with a nasolaryngoscope, usually a thin bore nasolaryngoscope, so as to ensure that there is some degree of comfort for the patient. The FEES itself is done in parts. Now, the first part is just an evaluation of the nasopharynx, the nose, the velopharyngeal movements, and the movements in the oropharynx, the base of tongue, the laryngeal movements, the vocal cord movements. We evaluate each of these without giving the patient any sort of feeds. Now, also at this part, which is one of the biggest advantages of doing a FEES over video fluoroscopy actually, is seeing secretions. Now, secretions, not only secretions per se, the response, patient's response to secretions, the amount of secretions, the location of secretions, all of these make a huge difference to the ultimate outcomes for these patients in terms of swallowing. Now, if a patient has copious amounts of secretions in the laryngeal vestibule, that probably is not a patient in whom you would be very comfortable going ahead with feeds.
Very nice. I mean, that if a person can't clear his secretions, there's no way he's going to clear bolus. Yeah, it's a very good point. Secretions in the vestibule is a big red flag.
Then once this is done and once we are sure that the patient is able to tackle his own secretions, manage the secretions, then we go ahead with feeds. Then there are patients in whom there is still a degree of uncertainty wherein you would want to do a ice chip protocol wherein you would like to keep a block of colored ice over the patient's tongue, see whether the patient is initiating a swallow, whether the patient is able to clear that water.
Yeah, we'll come to that. So it's basically first part is like an anatomy, and then you decide whether you want to go in for the next stage or no. But in this, I would like Dr. Rashmi to speak a little bit on whiteout and laryngeal adductor reflex. Secretions Nilanjan mentioned is a very important point. The other important I feel is whiteout and laryngeal adductor. Dr. Rashmi, would you like to see?
After assessment, a primary evaluation, we ask the patient to swallow, and if there is an effective laryngeal elevation, the larynx should move upward and anteriorly so that there would be an opening. This initiates a swallowing reflex and opening up of the cricopharynx. If this, that is called the whiteout sign, the larynx gets out of focus, and that is why we get that whiteout sign. And if this is a bit delayed or absent, that's suggestive of a dysphagia. The patient would be having a difficulty in swallowing, and that would be the reason for the residue in the pharyngeal.
Laryngeal adductor reflex.
And laryngeal adductor reflex when there is a sensory deficit, when there is a
sensation is impaired.
Sensation is decreased. Normally, when there is a minimal amount of secretions going into the larynx, naturally the vocal cords should adduct completely to protect the airway, and this is lost when the sensation is lost.
Yeah.
And
we touch with the endoscope the laryngeal surface of the epiglottis or the AE fold, and we look for the laryngeal adductor reflex. So this first part, we also decide whether we can take the patient up for next stage of thing, whether to give a bolus thing. This is one of the findings. It's just a thing, unilateral pharyngeal paralysis in a brainstem stroke. Okay, it's a thing. So now, Dr. Shama, after you did a first part thing, you feel that you can take him up for the next stage. That is where you start giving the bolus. So what are the protocols you follow, and can you take us through the next stage, please?
Yeah, so when we start giving bolus of different consistencies, so the consistencies which we use is basically liquids, honey thick substance like a jelly or something. Then you can also use some fruit mashes. You can use for Indian palate, Indian food, you can use something which is very squishy like a khichdi and solids. These are the few consistencies which we check. the first food or the consistency which we give is generally which the patient is comfortable with is what we follow. And then we give them basically in the beginning for liquids, if we are trying, then it will be 1 ml, 3 ml, and 5 ml first, if they are able to take it, and then we go to 10 ml of liquids, depending on how. The similar protocol is followed for all the other consistencies. So when you are looking at the face, we come to know that which consistency the patient is able to swallow, which consistency there is aspiration or there is no aspiration, and what amount of food is the patient able to tolerate. Whether in some cases it may be possible that for 5 ml the patient is not aspirating, but if you give him a higher amount or a bigger amount of bolus, then he might aspirate. So this helps us in evaluating the level of oropharyngeal dysphagia, as well as to decide a dysphagia protocol for them, the food protocol for them.
So what is safe to feed the patient? How much? So if he's
Yes.
having issue with 10 and no problem with 5, we can advise him to take small feeds, only 5 ml at a time. Dr.
Yes.
Manju, what is the protocol you follow? Is it the same or?
Sir, can I add few points in the
Please. Yeah. Sure. Go on.
One point I want to emphasize is that while doing fees, the patient has to be in a physiological position for a normal swallowing, like sitting position, preferably. But most of the cases,
Very
some
good.
patients are not able to sit. So in those cases, you have to make the head end of the bed in an elevated and supported posture, so that the patient is able to swallow safely. And the second point is the nasal cavity can be decongested with the decongestant drops. And generally, I don't use any anesthesia while doing fees examination, because that will hamper the sensation of the pharynx and will give a wrong result to us. That is second point. And third point is colored food, like a methylene blue dyed water or a contrast color can be used, like a green color. Never use a
additives, yeah.
chocolate color or a pink color like strawberry ice cream or chocolate ice cream for testing, because that will never give a contrast. And while doing with a flexible scope, a channeled scope for suctioning is preferable. The patient should be like connected to the pulse oximeter, and vital should be monitored, and preferably it can be done in an ICU setup, like in a acute stroke event patient. So these are the points I wanted to add in the initial phase. And another point is, like in the fees consist of like 3 parts of examination. So in the initial part, like Dr. Nilanjan has rightly pointed out, like it is the testing of the motor sensory system. So the laryngeal adductor reflex, as we have discussed, can be tested in the initial part itself with the tip of the endoscope, so that we are like, that will be able to reach at a conclusion that whether we can give like feed, semi-thick consistency or water. And the pharyngeal squeeze maneuver also should be assessed in the initial part itself. Like the patient, we can ask the patient to phonate E, like a forceful, effortful E, so that we can see the thyropharyngeus muscle that is contracting and coming close to the larynx. So that is pharyngeal squeeze maneuver. This can also be added in the initial part. So
Okay.
after that, we can proceed to the like giving water.
Bolus, I mean, is there anything different you do? Thanks for this valuable input. Yeah. And Dr. Please go on. You want to add anything, Dr. Manju?
Nothing. Depending upon this finding, we can proceed with the water solo, semi-thick consistency, all this.
Okay. So anyway, this is the thing I follow. Nectar liquid. We start with 5, 10, and 20. Dr. Sharma said 1, 3, and 5. So each one has their way. And these are the things which I follow. Either kanji, low-fat skimmed milk, or mashed banana with some coloring agent you can do is a thing. Dr. Farah, would you like to add anything? This is a normal. The video is playing. You can.
The thing is, I think what we need to be more clear about is when we are talking about the consistencies that we are giving, we have to give these consistencies multiple times. Like giving once and assessing only once is not sufficient, is what we do. We have kept a protocol as thrice at least, unless there is overt aspiration to whatever the patient is taking, then we stop. That's the only thing that I would like to add here.
Okay. And
I
another
would
thing,
like
I mean,
to,
yeah.
There are studies to the effect that if you are not feeding any particular consistency thrice, you may not get meaningful results. So
Right.
Correct.
times for each
Yeah.
consistency is probably a good idea. Yes.
Yeah.
Yes.
And anyway, I just want to clear one because Dr. Manju said the endoscope should have a channel. Channel endoscopes are a little expensive. I mean, let's not talk of laryngologists like us, even a routine ENT surgeon. Does everyone have a channel endoscope, or you have an endoscope
So
without channel also?
can
Because I
I
use without channel. So it's
I use
okay
with
even if you
channel.
don't have channel.
can I take this one?
Please take it.
So I have used both, and I frequently use both. We have both the endoscopes, the channel and the non-channel one. While you do have a certain measure of assurance when you use a channel endoscope, one, because if there is any penetration or if you want to clear some residues, you can use the channel endoscope. The problem with channel endoscopes is they are thicker. They are they are wider bore as compared to your routine flexible laryngoscopes. So introducing through the nose might become a little difficult occasionally, and some patients tend to get a little uncomfortable with it. So on a routine basis, I always use a non-channel endoscope. But then, yes, the channel gives us a measure of safety, no question about it.
Okay. So anyone,
Can I
ma'am?
add?
Yeah, please.
I generally use channel scope. Yes, they are whiteboard, but if you are used to doing them and use a jelly for a lubrication, I don't think there's a problem going through the nose as well, because most of the times they easily go. I mean, till today, I've not had any problem
Okay, good.
where the
See, the
patient
thing is, basically, I don't want to give an impression to people starting recently that without a channel laryngoscope, you can't do swallowing assessment.
That's true.
If you have a channel, it's good. If you don't have a channel also, please go ahead.
You
Keep
can
the question
just-
ready.
90% of my
And
field examinations are done without
yeah.
channel
So
endoscope.
that is, I don't want that. That is what I meant. Okay.
regarding consistency,
Yeah,
obviously,
please, Rashmi.
I would like
And
to add
also
one
you
more
can,
point.
after you answer that, you can just mention about these features, signs, spillage, residue, and penetration. Please go on. Yeah.
Yeah, so the first consistency which is to be given is based on the bedside evaluation. If which one is safer has to be given first, and then
Sure.
move on
Very
to
good.
the
Yeah.
unsafe ones
Good.
in
Nice.
smaller
Yeah. Would you
quantities.
like to elaborate on the signs, please?
Maybe understanding where the stroke is probably also might give us a certain degree. Your first part and the stroke might give us an idea as to which consistency might be a little better for the patient. A patient with a medullary stroke might not do so well with semi-solid or thicker consistency.
Correct.
Something like that.
Yeah. Sure. So now that we'll move ahead. So Rashmi, could you just elaborate the signs? What we look for? You started to bolus. These are some 4 important, I think. If you don't mind, can you just?
Yeah. First thing we need to look for is a premature spillage. That is, if the tongue mobility is altered, if the fine control of tongue is not there, the bolus cannot be moved in a controlled way. The propulsion of the bolus may not be adequate. So there would be a premature spillage, and immediately the patient would be coughing immediately after a bolus. And residue, the bolus can be retained at the level of vallecula, piriform fossa, or all over at the level of vallecula, piriform fossa, as well as the postcricoid. Usually isolated in the vallecula usually occurs when there is a tongue mobility issue as such. When the laryngeal elevation is affected, the residue will be at the level of vallecula as well as at the both piriform fossa. And if it is severe, we can have it at the postcricoid region too. And penetration. This can occur when there is a primary as well as a secondary of, that is immediately after a swallow. If there is penetration, that is the food going into the airway but above the level of the vocal cord, that is called penetration. And if it goes at the level of the vocal cord or beyond it, we call it aspiration. And it can be primary or secondary. Primary means immediately, it's usually due to a premature spillage. Immediately on swallowing, the patient will have a little amount of food going into the airway. If it is above the level of airway, penetration, and below it, it's aspiration. And it can be a secondary one too. When there is significant residue on multiple swallows, after 2 or 3 bolus, there would be a secondary cough developing because of the spillage of secretions into the from the residue. And these are the major.
Very nice, very nicely elaborated. So when you do the second part, you look for these 4 major signs, if they are there or no. Dr. Farah, you do scoring in all patients, or how is thing?
I would like to score in all patients, sir. Number one is it becomes very easy when we are communicating to another physician as to what we are seeing. So PA scale, though it was initially used for VFS, but then it has been modified and used for fees as well. Also, number 2 is for follow-up visits. So once I know that the patient was passate and I'm doing a fees after a month to assess the improvement, it's more of an objective assessment of penetration aspiration scale specifically.
Very
So
good.
yeah, scoring is good.
Residue, or you score or you don't score that also?
Residue, though there are scales there for that, but I am not very keen on
Keen
scoring
on
them specifically. But Murray scoring for secretions, I definitely do make a point that it's there in my reporting.
Could you just briefly mention? Very live.
So Murray scale is grade 1, 2, 3. That's when we enter into the larynx in the initial examination, how Dr. Nilanjan was talking about. Grade 1 would be there is no secretions involved in the laryngeal vestibule at all. Grade 3 would be there is a lot of secretions in the laryngeal vestibule. And 2 is when there is an alteration happening between 1 and 3. So that helps us assessing and analyzing as to basic, before we go for pass, Murray would give us an understanding of what's the scenario for the patient.
Okay. Anyone else would differ, add, change? Please feel free.
So for residues, I always do a scoring according to the Yale residue scale based on whether it's a piriform fossa residue or a vallicular residue. And that's the only, and yes, I do the Murray scaling for the secretions too. That is how we do. But then residue scoring, I feel, is important because in a lot of brainstem strokes, the improvement in residues is something which might give you an idea about the patient's evolution, patient's improvement over time. So
good. Yeah, nice point. That's a good point. Yeah. Dr. Chama, would you like, what do you follow?
I basically I do the PS scoring as well as the Murray's secretion scoring. Residue, I do mention if I find that there is too much of residue which the patient is having, and where there is complete pharyngeal, where there is the pharyngeal wall is all covered with residue, or there is a lot of collection after the bolus and after the swallowing. That is when I decide that I need to do it, because as Nilanjan said, it helps us in basically seeing whether the patient is improving
Progressing
later on.
or whether a treatment.
But,
yeah.
yes.
So basically now in fees also we first did a dry endoscopy, then we fed, then we saw all the findings. Why we did all this? To find out from the clinical signs what are the physiological parts of swallowing which are affected, so that we can plan for management. So this is a very simple, we'll discuss that in little detail. I'll just show a video. So we saw this patient was having little residue and thing. After a chin tuck, you can see that he was able to swallow. I will come back to this maneuvers a little later. We'll discuss. I'll just. See, after a chin tuck, everything got cleared. So this is how you see and is a thing. Dr. Manju, now what about modified barium swallow? What are the, do you use them? I mean, use this investigation in all your patients, you select, because I assume as ENT surgeons, flexible endoscopic evaluation is our mainstay. So would you like to, what protocols you follow, please?
Yes, sir. The first instrumental evaluation is flexible endoscopic evaluation only. But while we do this flexible endoscopic evaluation, there are a certain category of patients, based on the area of their stroke, or we feel that there is a penetration, patient is clearing or not, when we doubt that this is the patient clearing or not, or when there is an aspiration, patient has a weak cough reflex, or some problem is there in the sensory pathways. This is the point at which I want to do a fluoroscopic evaluation. Like, for example, if the area involved is, say, cerebellum, then I would definitely go for a fluoroscopic evaluation, because the timing, the incoordination, the aspiration during the solo, during the actual process of solo, the quantity of aspiration, the clearance, how the patient can clear, all this can be well seen with the
With
fluoroscope.
a modified fluoro. So it's not routine you use in selective. Dr. Rashmi, would you like to add anything?
No, only in selected cases I go for it. If there is a doubt regarding the chance of aspiration, if it's a clear-cut aspiration, that's no point in going for a video fluoroscopy. But if you have a doubt whether there is an aspiration or not, definitely we'll opt for the video fluoroscopy
Yeah,
to
so
decide.
generally if you're, yeah, Shama, please, yeah, you were.
No. I just wanted to add that even it is difficult to know if we are in doubt with aspiration, we do go for VFS. But we can also use a small trick if you have a NBI with you in the scope itself. Then what we can do is you can switch on the NBI and see if you're using a green colored dye. The green colored dye looks red on NBI, and so that is one thing which you can use when in doubt for aspiration while doing fiber optic evaluation. So
Okay, so basically you don't use in all in a selective patient, more so when you're suspecting oral stages or upper esophageal sphincter problem. All of y'all, anyway, I know many of y'all are in corporate hospitals, but for an average ENT surgeon, it's also a thing. If you don't have a video fluoroscopy unit, you can also use the CM, which the orthopedic surgeons, I'm sure any hospitals have, and you can also use that thing. Dr. Nilanjan, would you like to add anything?
So I decide on a video fluoroscopy based on my Fields findings always. So if it is the upper esophageal sphincter region, a poor upper esophageal sphincter relaxation, that is when I actually would like to do a video fluoroscopy. Rest everything else in the pharyngeal stage is, according to me, pretty well documented on a Fields examination. I'm not sure what this seems to be, some sort of a.
No, it's only to highlight. So this is, I thought, for people. So you could highlight. This is the thing
There
is
is pooling of the dye in the upper esophageal sphincter region. So most likely there is poor relaxation there. That is what
No,
seems.
this is in the vallicula, I think.
this is vallicula, yeah,
This
because
is
upper
vallicula.
below
This
that,
is
this
just
will
below
come
piriform.
that.
down.
This is,
No, just below
yeah,
that.
yellowish color is penetration and little aspiration here, the lining of the trachea.
The pharyngoesophageal
I
sphincter will
think
come here.
I think the aspiration is a result of the residue buildup rather than an
Correct.
active. It
Yeah.
seems
So
to be a
this is,
passive aspiration rather than an
yeah,
active
yeah.
aspiration.
So I took just a still shot so that people will be able to appreciate. Once again, vallicula, piriform sinus, penetration where bolus enters vestibule above the vocal folds, and red arrow is a big red aspiration into the tracheal wall. So this is how we look. And Dr. Farah, would you like to add something? This is the spillage.
So, once the bolus is in this patient's mouth,
It's
I
from
see
the
that
recording. I'm not telling anything. Sorry.
yeah, no issues, sir. The patient has very weak oral propulsion, is what I'm seeing. Though the tongue is not very clearly visible in this. There's a lot of premature spillage. This is an AP view of the VFS, which is showing some residue on the left piriform. When we do VFS, we do lateral as well as AP films. I just would like to add that VFS actually is dynamic and amazing to detect primary aspiration. Many a time it's very difficult in fees to detect primary aspirations if it's not very, overt and large amount. In this, along with the lateral aspect, AP view becomes more important to know the side of the weakness, which side of the piriform or the vallecula there is residue, like here it's in the left side. There is a lot of dilatation of the hypopharyngeal area, even in your previous slide, which indicates that this patient also has a lot of pharyngeal weakness. But along with that, I would like to evaluate the upper esophageal sphincter in the previous one, sir. Yeah.
This is another video of aspiration. So I'll just show you. You can.
We can see that, the laryngeal vestibular closure itself is so deficient. The epiglottis is not completely closing the laryngeal vestibule. And this is almost like a bronchogram where everything is entering into the bronchi.
Correct. It's a massive aspiration and no cough. So is a thing. And Dr. Manju, would you like to add a little bit on upper esophageal sphincter opening, cricopharyngeal bar? This is a.
Yes. We can see that cricopharyngeal bar in the posterior pharyngeal segment opposite the cricoid area. So that is the
And,
cricopharyngeal bar seen in cricopharyngeal spasm.
correct. And this is a piriform sinus residue, vallecula, and a little aspiration also.
Yeah.
So all this is what you do. And does anyone use high resolution manometry? I know Dr. Farah and Shamad use a lot. Nilanjan, do you also use?
Not very frequently,
Not very
but it's a good tool, especially when you want to know about upper esophageal relaxation issues, sometimes for pharyngeal contraction issues too.
Okay. Would you like to elaborate, Farah and Dr. Shama, because I think you all use this. Anything you would like to say?
So, sir, we use this mainly when we feel that there is either an upper esophageal sphincter issue or a lower esophageal or a reflux kind of things which a patient presents with. It's basically done whereas multiple electrodes are placed inside the esophagus. This is generally used for esophageal dysphagia, wherein you can find out esophageal motility disorders also. So this checks about the pressure in the lower and the upper
esophageal sphincter opening and pharyngeal contraction, also some information. So finally, we did a screening. There was a problem. We did an instrumental evaluation. We found out what are the signs. From the signs, we deduced what are the physiological basis, and we then plan for management. One very important thing is biofeedback, where you have to educate the patient for any maneuvers or thing. I'll use a case to just go ahead. So don't worry too much about the findings. So this is a 14-day post-supratentorial stroke patient whose Ryle's tube was removed and he was fit for discharge. The neurologist wanted to know if the RT tube had to be reinserted or what was the advice to give him before he is discharged. So this is what 5 ml liquid. These are his fees video. And this is with 10 ml. You can see, so this was my findings. I've added a little bit because they're not videos are there. This is briefly what was seen. Anyone would like to add of any of the findings, or you're all okay with this? Is it okay?
Yeah.
Okay.
Yes, sir.
So, yeah. So then, so with this, then how are we going to manage the patient? Dr. Farah, would you like to take the question? You start.
I think it's better to put the RT back. If
Yeah.
you're planning
Okay.
to
No, but first
discharge.
for to just we are using a case for thing to just the principles broadly. What are short term, long term? What are just
So
then?
in this patient, clearly the safety is impaired, the efficiency is impaired, the cough is extremely weak, so the patient is not ready for a oral feed. That has to be clearly mentioned to the patients and the relative. Number two, with those trials, were there any trials where the patient was not aspirating, sir,
Yeah,
any
I'll come to that.
compensation?
We'll start with this and then next we'll go. I want to go use to discuss thing. So it's
So
a
if
broadly
this,
like how Dr. Farah said, we have to pulmonary safety and nutritional integrity is very important. So management is broadly short term and long term. This is what we did. We reinserted the nasogastric tube and then oral care and diet support. A little bit, I mean, like how you mentioned. Chin tuck orally was there, and again RT feeds plus oral feeds were started. So anyway, with swallowing exercises, we were able to wean the patient out and thing. So I'll just use this. Dr. Rashmi, what are the criteria? Anyway, Dr. Farah said safety issue is very important. Once there is a stroke patient, not only this patient, what are the criteria you follow? That is it safety is the only concern or thing, whether to insert over a nasogastric tube or a PEG or what? Both in the sense, I mean oral and nasogastric. I'm not saying nasogastric and PEG. I hope there's no, yeah.
The criteria usually based on the fees and other evaluation. If the patient can safely manage the secretions, then maybe we go for a trial of oral secretions and oral trials with multiple consistency. And if the patient can take feeds adequately, then no need for a nasogastric tube. But otherwise, an alternate feeding method should be there for the patient.
Yeah.
Along with it, swallowing therapy techniques has to be
We will
tailored.
start that, yeah. So everyone is quite uniform in their thing that if safety issues are concerned, you have to insert Ryle's tube. Is there anyone in a first preference would go for a PEG or you would try a nasogastric tube and then go for a
But this here is probably not a binary yes tube or no tube. And this particular patient, of course, a tube was required. What I meant to say is out here, where the stroke is, what sort of effect it is having on the patient, what is the long-term outcome of this stroke, how dense the stroke is. All these things matter in deciding whether you want to put in an NGT or now. This is a supratentorial stroke, probably a thalamic or a basal ganglia stroke from what the look of it. These are patients who usually recover sooner, and that has been seen. You got the NGT out in 18 days. Were this a lateral medullary syndrome again? This is of course not the picture of a lateral medullary, but I'm saying that is probably a patient in whom you could start counseling for a PEG tube at the very outset because you know that this might go on for some time, especially depending on your fees findings or your VFS findings. Again, coming to the fact as to swallowing safety, well, of course, swallowing safety is definitely a factor, but then if a patient has good pulmonary status, if a patient has cough reflex, and the patient can take small amounts, very small amounts of, say, not thin liquids, but slightly, thicker liquids with maybe penetration, but no aspiration, I might try them with some, the safer consistency, sir. Maybe try a supraglottic swallow.
Yeah. So consistent in the sense you would alter the consistency
I would
to see.
alter the
Yeah.
yes, I would
Could
try
you
to give
a
them
few
feed.
lines on that altered consistency for the benefit of the viewers? I anyway have a slide, but you could just.
Altered consistency. Well, there are now artificial, or rather, there are substances which can change the consistency of your regular feeds without changing the taste of it. So even starch, as you have mentioned out here, can be used to thicken the consistency of water or thinner liquids. So changes in consistency, especially for patients who have supratentorial strokes, can be quite effective in preventing aspiration, especially when they are having active aspiration post premature spillage.
Yeah. So it reduces the velocity of the bolus flow.
Yes.
Time is running out, so I'm just going a little, please. So Dr. Manju, so then would you talk a little bit on postural adjustments?
Yes, sir. So this is with the postural adjustment is a part that we add to our instrument evaluation itself. If we understand the pathophysiology of what is happening for the pharyngeal dysphagia or oropharyngeal dysphagia. So, excuse me. So for that, like as a last part of the flexible endoscopic evaluation or fluoroscopic evaluation, I will do this, the postural adjustment. For example, like there is pooling in the pharynx, the cricopharynx is not opening that great. We can ask the patient to do the chin tuck, that is one postural adjustment. Or when there is a pooling in one particular piriform fossa, you can ask the patient to turn the head to that side, obliterate, and the bolus will pass through the normal side. And the patient.
So in other words, you are bypassing the problem. You are not treating the problem,
And
because treating the problem will take time. So for the time being, you will alter the consistency, or you will teach maneuvers
and
so
will
that
see that this is
working or no. Yeah. And then after that, you need full-time recovery. So you would teach exercise. Dr. Rashmi, would you a few lines on swallowing exercise? Because all these maneuvers and consistency is only temporary. We need a proper recovery. Yeah.
Yeah, it depends on the site of involvement of the stroke. Usually, as said, for the cortical, if the cortical brain, supratentorial lesions, even though there is no neurological involvement, it is mainly a sensory involvement. That is a swallowing agnosia or apraxia which is occurring, and because of that, patient doesn't know that it has to be swallowed, or patient is unable to understand that this thing has to be swallowed. So we need to give a sensory stimulation for that, improve the sensation, and then improve the exercises. And if it is at the level of the brain stem, usually the neurological involvement, multiple cranial nerves are involved, and there we go for two types of swallow therapy. One is a indirect swallow therapy, which is basically a muscle strengthening therapy without giving any food bolus, especially if it's an unsafe swallow, to improve the improve the muscle strength. And next would be a direct swallow therapy. That is where you give bolus in small amounts, and with slight modifications in technique, we teach them how to take the bolus safely. So depending on the site of it, it could be from the level of the lip. Because of the decreased lip competence, the indirect swallow therapy would be pressing the lips. It's something like a straw exercise, placing a small button and ask them to, with a resistance, ask them to take it out when they are sealing it, or tightly touching the button with the lip. And tongue exercises to improve the strength. That is the muscle strengthening exercises, or modify the site where we are giving. You can direct the food through the normal site so that the bolus can be taken back towards the pharynx. And or a jet feeding technique, you can directly take the food bolus towards the back side of it. Or
so
if it is a
exercises we can do. So exercise will help in long-term recovery of the muscle.
Yes.
So for short-term, we did Ryd's tube feeding, and then we altered consistencies, we gave maneuvers. And for long-term, we are giving exercises with sensory stimulation. thing. So swallowing exercises is an important part of treatment, and motivation, frequency, adherence is very crucial. But then afterwards, we have also realized that just simple exercises will not help, because for long-term rehabilitation or recovery, there should be increased neuroplasticity, or synaptic activity should change in the brain. Dr. Farah, would you like to mention about neurostimulation techniques we use?
So this is most of our new favorite for the past, I think, 3 to
I
5
know it's your
years.
favorite, so only I asked you. Yeah, yeah.
Neurostimulation, basically what we practice is transcutaneous neuromuscular electrical stimulation, which we call as NMES. They work on the principle that when there is some amount of current that is being supplied to the motor units or the muscles involved, most commonly being the suprahyoid muscles, they help in enhancing the number of motor units that are responsible for contraction at a time. And at the same time, because of the stimulation at the motor end potential, there is some amount of neuroplasticity also working at the same time. But what we need to understand is doing NMES without swallowing exercises is of no use. So basically, it's to enhance the amount of activity in those muscles, which, say, probably there's a person who's not eaten for quite some time or not had any oral swallow for almost 3 weeks, 4 weeks, then NMES and that tingling sensation that they feel does help us in swallowing therapy or swallowing training. This would be neuromuscular, but there are a lot of central stimulation techniques like transcranial stimulations, transcranial magnetic stimulations, which definitely, so you do it quite frequently at NIMHANS, wherein that also aids in neuroplasticity.
Yeah. So basically, for the viewers, is that any exercises you give or any rehab should be accompanied by neuroplasticity changes in the brain. So we have various agents to stimulate neuroplasticity. Broadly, they are divided into peripheral and central. This should be an adjuvant of exercises and rehabilitation. It can't be an standalone treatment. I'll just, Mr. Bhaskar, how many minutes do we have? Okay, so this is just in the thing, I mean, the stages where each stimulation agent, where it acts and things. So neurostimulation is also an important part of any post-stroke dysphagia management. And also like brainstem, and sometimes there could be unilateral local fold paralysis. Yesterday only, Dr. Jaykumar Menon has had a long talk on this, and he has mentioned. So, Dr. Shama, would you like to just briefly mention? I mean, not in this case, but generally it's also, as ENT surgeons, we should know in
Yeah.
dysphagia management. Yeah, please.
Yeah, so when you have a unilateral vocal cord paralysis and if the patient is aspirating, then we have multiple options what we can do. So injection laryngoplasty is basically if it's a very early vocal fold paralysis, less than 9 months, and you want to give a temporary relief to the patient, then see how the aspiration goes. It's always better to inject a filler into the paralyzed
What
vocal
filler you
fold.
use, please specify.
Hyaluronic acid is the filler
Which
which
is
we
available
use,
in
which
India.
is available as Restylane or Juvederm in India. That's the only filler which is available. Nothing else is available, or else we can use fat, but that's a permanent, like a permanent solution. Once the injection laryngoplasty is for, once that is passed, that period is passed after 9 months, if you want that there is no improvement, the aspiration is still present, and the vocal folds are still paralyzed, then you can go for type 1 thyroplasty, which we do with Silastic block, where you create a window in the on the side of the paralyzed vocal fold in the thyroid cartilage, and then we shape a
Medialize the
Silastic
vocal fold. Yeah,
vocal
that's
folds.
okay.
Yeah.
Yeah. Dr.
Non-selective.
Manju, go on.
Yeah, okay.
Dr. Manju, you do a lot of non-selective laryngeal reinnervation. Have you done anything for any post-stroke patients?
Non-selective reinnervation, the thing is the effect of NSR will come late. Like it will take some 5 to 6 months for the effect. But what we do is like while doing an NSR, we can inject the vocal fold at the same time with the hyaluronic acid gel. That's what we do. So that will
No, I asked, have you done in any stroke patients? I mean, yesterday sir's spoken about the technique. Yeah.
Yes. Like for a few patients, but it is like when they end up in a, like after the acute phase and all, like we wait for 6 months, 6 to 8 months at least, like in any standard
Okay. So
cases.
then in
After
acute,
that,
it's not,
yeah.
so injection laryngoplasty is the mainstay.
Mainstay.
And Dr. Nilanjan, would you like to, the other place where as ENT surgeons, we might be intervening, especially brainstem stroke is where impaired relaxation of the upper esophageal sphincter. Dr. Nilanjan, could you just take us this, please?
I would. So this again will depend on your video fluoroscopy findings and your fees findings, of course. When you're sure that there is an upper esophageal sphincter relaxation issue, as you mentioned rightly in brainstem strokes more commonly, then that is where we can consider doing an injection Botox under, I prefer to do it endoscopically under general anesthesia. So what we usually do is introduce a scope, rigid scope, and then through it, do a the posterior and 2 lateral points Botox injections so as to try and relax the cricopharyngeal muscle.
Reverse the Mercedes. Yeah. Okay, Benz. Yeah. Okay. Yeah.
And also sometimes when there is some spasm out there, even dilatation, balloon dilatation of the upper esophageal sphincters also do help. But then Botox is, at least for the short term, Botox has been found to be more effective.
Yeah. Anyone else would like to add? Anyone does any myotomy or anything? That's also.
So if these things fail, that is only when we go for an endoscopic CP myotomy.
CP myotomy. So yeah. So this is routinely not done. It's mainly for brainstem stroke. But as ENT surgeons, this should also be there in our armory and things. So this is, you can see that after Botox, the barium is for passing quite freely is the thing. So anyway, but for surgical, I would like to warn that case selection is the key. There are a lot of local criterias, in my opinion, upper esophageal sphincter treatment will work only if there is a good pharyngeal contraction, then patient's general condition, neurological, all this make criteria are very important. They should be considered. Yeah, please go on, Dr. Sharma.
Just one thing I wanted to add was we were talking about cricopharyngeal dysfunction or spasm. We should always keep in mind how the hyolaryngeal elevation is when we are thinking about cricopharyngeal dysfunction. If the hyolaryngeal elevation is not proper and you give Botox, you may not get the result what you are expecting.
Very much
so.
Yeah.
That has to be kept in mind.
Absolutely. It has to be understood why the cricopharyngeal dysphagia is there in the first place.
Yeah.
So because CP spasm only then does all this.
Case selection is very key, is the key. Yeah. I think we have come to the end of the thing. I hope we have tried to cover. Anyone wants to make a quick point? Please, anyone is free to do anything.
I think we have covered almost everything.
Everything. I don't know if we were a little fast. So anyway, if any doubts, please reach out to any of us. I'm sure we'll be able to help you all. Thank you very much for.
Thank you.
Thank you so much.
Thank you so much. Thank you,
Thanks to all the panelists and to Microlabs, Trustwell Hospital.
The recording.
Should we leave?
Yeah, I think looks like we have made them to sleep.
He has to stop the recording.
Yeah. No, they will edit it. I've stopped it. I stopped it.
No, sir, it's still recording.
Recording. I
Yeah,
can't
Yeah.
stop. Okay, they'll edit the last part. Don't worry. Adike, we took some time.
Yeah.
We can't stop, is it? Okay, I'll call Bhaskar. I think he's left.
No, there's
There
someone
is
in
some
digital
digital.
infomedia there.
yeah.
There is someone from Digital Infomedia, but I think they've left.
No, I think he just logged in. Starting my OPD now.
My God.
Private practitioner, man. काम करना पड़ता है.
ಭಾಸ್ಕರ್ ಆಯ್ತು ಎಲ್ಲಿ ನೀವಿಲ್ಲ ಅಲ್ಲಿ ಮಲಗ್ಬಿಟ್ಟಿದ್ದಂಗಿದ್ದೀರಾ ನಮ್ದು ಆಯ್ತಾ ಇಲ್ಲ ಆಯ್ತಪ್ಪ ನಿಲ್ಸು 1 year 1 hour ಆಯ್ತಲ್ಲ 1 minute ಹೌದಾ ಆಯ್ತು ಮಾಡ್ಬಿಟ್ಟು ಸ್ಟಾಪ್ ಮಾಡಿ ಆಮೇಲೆ ನೀವು ಲಾಸ್ಟ್ ಪಾರ್ಟ್ ಎಡಿಟ್ ಮಾಡ್ಬೋದಲ್ಲ ಓಕೆ 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 ಓಕೆ
We are all on the screen.
Yeah. Talking whatever we want.
He's not yet stopped recording.
No, he said he is in some other another meeting. He is coming in. I think they have a lot of recordings. I think there are a lot. This starting at 8 o'clock in the morning. Saturday, I think there are again a lot of talks. Doctor,
When this relay happening, sir, on Saturday?
Sunday. We are
Sunday
on
morning.
Sunday.
Sunday
Saturday
morning.
is surgery. Yeah, I think he has shared it in the group.
8 o'clock or 8:30 something.
8 o'clock, 8 to 9 is the thing.
So if you want to see yourself, you have to get up early on a Sunday and watch yourself.
And you have to dress up nicely and sit and watch.
What's the point, sir?
But I'm joking.
Nice to hear.
Anyway, nice. I think we had a nice time. It was a
It
very,
was
very
good, sir.
relaxed,
Very
casual
good, yeah.
thing.
Dysphagia
Thank you,
1
sir.
hour, sir.
This
Yeah,
page and 1 hour.
Yeah, we had a 10-minute panel on in Mendcon if Nilanjan and Para remembers.
It was like, yeah, what he says, I concur.
Okay, Bhaskar, I think we took little more than 1 hour. Last part you can edit and remove. Okay.
Yes, sir. Once it is done, I will share you that recording, sir.
Okay, sure.
And second thing, sir, on the day of the panel discussion, who will be there to receive the questions and answers?
Yeah,
Sir?
I think we'll be there. All of us will be there. Don't worry.
Oh, thank you so much, sir. Thank you so much. Thank you
8
so
to
much.
9, so we'll be at home. No problem.
Okay, sir. Okay, sir. Thank you so much, sir.
Okay.
So Sunday morning we have to be there.
Yeah, who all can be there? Let them be there. You be there. You said.
How are we going to get the questions? It'll be
Sir, I will 1 minute, sir. I will show you. First of all, sir, I'm sharing my screen. Sir, in the Google, this
is
will
a
be telling.
WhatsApp chat.
One minute. 1 minute. So here we are having Entrain Live. Entrain.live. If the type, it will take to our Entrain portal. This is our Entrain. Oh, already I have logged in. I will log out and I will show you some 1 minute. This is our Entrain.live portal. When the doctor scan our QR code or if they type Entrain.live, they will land here. Here, the first time the doctor need to register these details. Tomorrow I will do all our panel members, faculty, surgeons, moderators, registration I will do. Here, if already is registered, if they click, they need to type their email ID. They need to type their registered mail ID. Once they type the registered mail ID, it will take inside the program. Here, we have uploaded the brochure, agenda. Agenda is available. Brochure is in the main home screen only. Brochure, agenda is here, and live event. If they go here, doctor can view the event. Here, the one more option called ask question in the bottom. Ask question. Doctor will ask the question that directly comes to us in the backend admin panel. We are active in the admin panel. The question will be diverted to respective surgeons and moderator. And also in this, we're having the previous year sessions. There will be one more instructor session. This will be, we are going to enable on the day of surgery, 22nd, and the event. Here, previous year surgery is available, and the books are available to download for the ENT surgeons. The otolaryngology concepts, gynae concepts, otolaryngology book is available. Pocket front atlas and temporal body section available. They can freely download by clicking the one above. There will be a dot. If they click that, first book can be easily download book, and second book below the epoxy there will be a red blinking light. If they click that, the pocket print book available. And this side previous year instruction sessions, all the things available for doctors to refer.
Okay. See you on
Very
Sunday then,
nice.
Bhaskar.
Okay, then we'll see you all on Sunday. Is a thing.
First of
Thank
all,
you, Mr.
thank you so much.
Bhaskar.
My
Thank you.
special thanks to Sanjay sir, because in my short tenure of 19 years journey in this profession, Sanjay sir was so sensitive and so means, sir, I'm very happy in the way you are responding, the way you are you responded to our program. I'm very happy, sir.
Well, thank you very much for the nice words. Really flattered. I think even the other panelists are equally good and they all support us. That is why we are able
Sir
to.
is the nicest person around.
Yeah. Thank you
Best
very much.
person to conduct a panel.
I second that.
Thank you very much. Thanks a lot. Thanks a lot.
Honestly, sir, I'll personally come and meet you, Sanjay sir.
Sure.
Honestly, meet you. I'm very happy.
No,
sir.
you should help us for Phonocon 2026. We are
Yes.
doing in Bangalore.
Yes, sir, definitely.
That is
proud of
our
sir.
yearly congress. So Microlabs, we are really looking for your support.
No doubt, sir. Definitely, sir.
Niman's Auditorium Convention. It will be near to your headquarters, so you should please help.
Yes, sir. Yes, sir.
Okay, thank you.
Sure, sir.
Thank you very much.
Thank you
Okay,
so
then
much,
see
sir.
you all. Bye.
Chalo, bye, sir.
Yes,
Good
bye.
night.
Bye.
See you on
Good night,
Sunday.
everyone.
Thanks,
Bye-bye.
everyone. Thanks,
Bye.
everyone.
See you again on Sunday.
Bye.
Bye, sir.